Okay. Thank you everyone for being here. Let's go ahead and get started. We are excited to welcome Dr. Lauren Gensler to join us as our speaker today at our Department of Medicine Grand Rounds. She is an assistant professor of medicine and psychiatry at the Emory University School of Medicine. She earned her bachelor's from Northwestern and completed her medical degree here at Emory. She went on to pursue combined residency training in internal medicine psychiatry here, and after which she joined faculty. She serves as the unit director for the Grady Medical and Psychiatry Unit, where she leads efforts to provide integrated, patient-centered care for individuals with complex medical and psychiatric needs. Her academic and clinical work is driven by a commitment to improve care for underserved populations and advancing equity and access to comprehensive medical and mental health services. She is deeply involved in resident and medical student education through clinical electives, didactic teaching, and mentorship. She's also core faculty in our internal medicine psychiatry residency program, contributing to curriculum development and program leadership. Additionally, she's an active member of the Association of Medicine and Psychiatry and serves as the co-chair for their annual meeting planning committee, which helps shape national conversations at the intersection of medical and psychiatric care. Thank you so much for being here today, Dr. Gensler.
Yes, thank you for having me. I am excited to share with you all about medical and psychiatry units, which are a response to complex care needs for patients that are often underserved. I will start with my disclosures, which I have none. The objectives for this talk is to review the provisions of medical versus psychiatric care in the United States, to discuss medical and psychiatric units, or MPUs as we call them, as a bridge between medical and psychiatric care, and to explore a little bit our new med-psych unit at Grady. And so we'll go over the structure, some of the outcomes, and then the lessons we've learned from starting the unit. I do want to start with a case. And so we have a 41-year-old male who comes in with a history of bipolar disorder, coming in for agitation and bizarre behavior at home consistent with a prior manic episode. He's agitated, tangential, difficult to obtain a history from, and his vitals show hypertension and tachycardia. The psychiatric ER team decides he needs psychiatric admission, but his labs return with an elevated creatinine of 3.4 from a baseline of 0.8 and a CPK of 15,000. He's admitted to medicine at this point, but he's disrupting treatment, refusing IV fluids, vitals, or lab checks. The initial Haldol PRN ordered is ineffective, and the on-call psychiatrist provides PRN recommendations, but can't see the patient till the AM. And so this kind of demonstrates the typical pathway for patients that have co-occurring mental health and medical problems who present to the emergency room. And so we see that patients that do not need inpatient medical care but need inpatient psychiatric care go to inpatient psychiatry, which makes sense. And then, of course, patients that don't need inpatient psychiatric care but need inpatient medical care go to inpatient medicine. But I want to focus on this middle pathway where the patients need both inpatient medical and psychiatric care. And they are admitted to inpatient medicine with a psychiatry consult. And so I think it's interesting to ask why this situation occurs. Why aren't they admitted to a psychiatric unit with a medical consult? And why is this kind of the more typical model that we have? And so, as with most things, a lot of it comes down to money. And the money is also tied directly to historical stigma for mental health. And it is pretty universal in all societies that there's been stigma against people with mental health disorders. Even the first recorded civilizations have documented the belief that mental illness is related to a personal failing or a curse from the gods. And stigma is still prevalent in a lot of countries in the world today, even countries that are very advanced and integrative in mental health care. And so because of this stigma, there has been a relative isolation between mental health and medical health developing and how we treat it. I want to go a little bit over the history because this explains kind of why why the system is what it is today. And so historically, prior to the 19th century, people with medical illness or with mental health illness were largely kept in homes or they were in jails, but very rarely were there psychiatric hospitals. But in the late 19th century, there became a push for more humane treatment of people with mental health conditions. And this is where we see the growth of psychiatric hospitals starting, or what later would be more termed asylums, these large state hospitals where people would basically go with mental health problems and they would live there. However, these hospitals very quickly became overcrowded, leading to deplorable conditions. Oftentimes, people that weren't just mental health complaints, so people that maybe had intellectual disability with behavioral disturbances or people with dementia would also get placed there. And so the overcrowding really led to a lot of problems. This changed a little bit in 1954, and this is when chlorpromazine was first approved for use. And there came with it the hope that mental illness actually could be cured, and that people wouldn't need to spend the rest of their lives in a psychiatric hospital. And this also occurred with beliefs that, that the hospital systems were inhumane, and a lot of press surrounding this too. So we see in 1963, so JFK signs into law that promotes community-based center for mental health treatment. And so we see that people are focused more on community-based mental health. They're starting to deprioritize these large state hospitals where people would live. In 1965, Medicare and Medicaid changed their reimbursement structure to only reimburse psychiatric hospitals that were 16 beds or less. And they also placed a lifetime cap on the number of Medicare days for psychiatric hospitals. This was largely done to reduce the amount of federal funding that was going towards treating patients with mental health conditions. They wanted the states to pick up and treat it, but that never really happened either. So through the 1970s, there is a sharp decline in inpatient psychiatric beds, which we continue to see throughout the late 20th century. The community resources that everyone talked about never truly developed. And so this left a lot of people without access to inpatient psychiatric care. In 1983, we get another hit to kind of the inpatient mental health system when the diagnosis-related groups came into effect, but they excluded psychiatry from them. So just like medicine gets reimbursement for more complex care, that's not the same for psychiatry. Psychiatry gets reimbursed based on this on a per diem rate, and so the daily rate for that was not really profitable, and there weren't a lot of new hospitals popping up. In 2002, though, this gets rectified and they are allowing some per diem adjustments to occur. And so they allow for adjustments, like if the patient's older, they might get a little bit more money if they're from a rural setting. But again, it's still not complexity-based adjustments for the psychiatric care. But this change in the reimbursements did actually change the profit margin and increase the amount of freestanding psychiatric hospitals that existed to care for people with who needed inpatient psychiatric admission. And so that brings us to our current situation where we have a network of private hospitals that are not affiliated with medical hospitals, and their profit margins are based on caring for a huge volume of patients in the shortest period of time possible with the lowest amount of medical acuity, because they don't get reimbursed for any medical acuity, and it's just money that comes out of their per diem rate. And of course, psychiatric complexity or medical complexity is not really considered for reimbursement. So again, why we admit patients medically when they have co-occurring psychiatric and medical inpatient needs is really due to money, and that is based on a lot of stigma. So the chronic stigma has contributed to higher medical reimbursements than mental health reimbursements. And because of this, the mental health and the medical systems have developed in relative isolation to each other, and has led to lots of private hospitals, psychiatric hospitals that have almost no medical acuity capacity, which has really siloed medical and psychiatric care. Our current situation is that we do have pretty ingrained healthcare silos, and so we see that integrated care is very rare, and the integration is like actually disincentivized based on reimbursement structures and how the medical system is set up. And so, unfortunately, this leads to worsening stigma. It worsens knowledge gaps for people. So if people are mostly in the medical side, they don't get a lot of exposure to the psychiatric management and vice versa. And it limits information sharing. And I think it's important to realize that these silos have serious consequences for everyone involved. So we know that for patients specifically, there are huge consequences to these silos. Um, so we know that with people who have serious mental health disorders also have much higher rates of chronic conditions like high blood pressure, smoking, heart disease. And this kind of lifestyle, socioeconomic status, and stigma increases their overall disease burden. So they have a higher disease burden than the general public. And then they tend to receive substandard care for the disease burden and reduce preventative care. And that is a major issue, which then leads to a huge health disparity where we see that people with serious mental illness die about 15 to 30 years earlier than those without. And most of these have accounted for things like suicide. And have removed kind of like psychiatric reasons for premature death. So these are deaths from medical causes, not that are indirectly related to their psychiatric illness. For providers, this is important for us too. Silos exacerbate and perpetuate our underlying bias against patients with mental health disorders, which leads to really negative attitudes towards those people. And this also leads to impaired clinical decision making. So we have seen studies where providers are given a case and the two cases, the cases are totally similar, except that one has the patient having a diagnosis of schizophrenia, it literally just has that included in their past medical history, nothing about what their current mental health symptoms are. And the providers will make different recommendations based on the patient having a psychiatric diagnosis because they assume that they will be non adherent. And so they don't give them the standard of care. And we see that happen a lot, through, with our patients who have very severe mental illness. And then system-wide, there are big consequences too. So patients with serious mental illness incur much higher healthcare costs. They have higher utilization of services, especially emergency room services, which increases kind of the resourcing cost. Overall, their cost of care can be 2 to 3 times higher than someone without a serious mental illness. And we also know that length of stays increase for patients, for medically ill patients who also have mental illness. So when we think about, restoring the balance or equity restoration, I do think it's important to think about reimbursement parity. A lot of this would not exist if psychiatric care was reimbursed in the same way that medical care was reimbursed. There does need to be more substantial bias training and also pointing out when biases exist. It's also helpful for people who aren't psychiatrists to get increased exposure to patients with serious mental illness, and for psychiatrists, honestly, to get more exposure to medical patients as well. And then integration and kind of breaking down these silos is ultimately really important to provide the most comprehensive and holistic care. So medical psychiatric units are one form of integration. And so they kind of developed as a response to inequity that people were seeing in relation to how patients with mental health were getting treated within the medical system. The definition of a medical and psychiatric unit is that it has to be an inpatient hospital unit. It has to have all the technical capabilities of an acute medical unit. but the staff is also capable of managing high acuity medical and psychiatric conditions. The psychiatric acuity can vary widely on these units. Some of them will be like ours, where it will be more acute patients, but other units will focus more on delirium or lower acuity psychiatric issues. But most importantly, in these units, the psychiatric and medical care occurs simultaneously. So the treatment of both is happening at the same time. There was a recent study that was done by, there's a MedPsych unit consortium, which is a group of international um, like healthcare providers interested in integrated care, and they pulled some of these people who are involved in MedPsych units to ask kind of what are the core components that you need for a MedPsych unit, and really, these make sense that you need a separate dedicated unit, that there has to be psychiatric safety, that of course has to meet medical regulatory requirements, that it's licensed as a medical unit and as a regulatory unit. There was some feelings about whether it should be administered by psychiatry or medicine department. I can tell you those vary place to place, and probably doesn't ultimately matter that much who is the administrator of the department. So, in going back to the history of MedPsych units, they really show up for the first time in the U.S. in the 1980s at the University of Iowa. And shortly after that, dual training programs emerged in the United States. So, internal medicine and psychiatry, or family medicine and psychiatry training programs. And this has kind of created like this cyclical relationship where the the integration advocacy has led to more MedPsych units, which has led to increased interest in dual training, which of course leads to more people interested in integration and starting MedPsych units. And so over the last few years, we've seen a lot of combined trained faculty initiate or start new units. But worldwide, there are MedPsych units across the world, but they are really uncoordinated and they haven't developed kind of in a logical way. It's been more country specific and completely discordant from the US developing them. Right now, the Netherlands is in the world, or is the leader of MedPsych units. They certainly have the most, and they have the most integrated healthcare system between mental health and medical. So currently in the United States, about 3% of hospitals we think have MedPsych units. And so there was a study in 2018 where they surveyed about 50% of Medicare hospitals, and then 64% of those surveyed had MedPsych units. There are more MedPsych units that have opened since this survey, so it's probably a little bit higher, but not much. Worldwide, we do not have a good estimate of how many MedPsych units there are, although we do know that the Netherlands is the most studied and extensive, and they have 40 MedPsych units, and it's in 40% of their hospitals. And it's interesting because the Netherlands actually didn't really like codify integrated care until like 2010. But when they decided to do it, they've mandated that MedPsych units open in a substantial portion of their hospitals. So why do hospitals start a MedPsych unit? And it really varies a lot in the US based on a lot of factors related to patient population, how the hospital is structured, if they have a dual training program. And so usually we see that there is a patient population that is resource intensive, so taking up a lot of resources, that there are some behavioral symptoms that exist in this patient population, that you need to have a safer environment for these patients. And that might be because there are adverse events occurring, or that nursing staff doesn't feel safe with the current environment that they're in on the med surg floors. And Typically, there's also staff discomfort with this patient population, and that's because they don't feel like they have the tools, the staffing, to safely care for those patients. And as this patient population kind of starts growing and taking up more hospital system resources, the hospital then starts to look kind of for creative ways to streamline care. And this is how a majority of med psych units get started. And so they're based on trying to solve a problem, not so much following like an ideal for or a belief in integrated care. And these, the reason that this happens, that these patients are, not cared for well on med surg units is many. So, patients on a med surg unit are really confined to their room. And so it's very difficult for patients with agitation to stay in their room or to stay in their bed. And there's a lot of resources and time spent directing patients back to their room. The rooms themselves are often unsafe with multiple ligature risks or things that patients can injure themselves with. There overall is a paucity of safety monitors who are able to monitor the patients, and also the training for those safety monitors is extremely variable. And so how effective they are at monitoring the patient or watching the patient varies. And then staff ratios are designed based on medical acuity, not on mental health acuity. And so the high behavioral health acuity patients use up a lot of resources and put a lot of strain on the staff, both time wise and just emotional strain. The med-surg teams are also not equipped well for psychiatric management. And so your typical medical or surgical team has had very minimal psychiatric training. And it's really what they've learned on the fly in residency and what they remember from their M3 rotation in medical school. The consultants, when you get a psychiatric consult, they are not a co-management team. So they see the patient, they make recommendations, but the medical team is still the one that is getting the calls about the patient's agitation and trying to manage care over the entire day and night often. And so this translates into sometimes the psychiatric consult team doesn't realize that there needs to be an escalation in psychiatric management because there's a lack of communication. There's also lots of concerns about medication interactions. So the medical teams are concerned about the psychiatric medications and what side effects they can cause. And the psychiatric team is worried about the medical illnesses and how they might be affected by the psychiatric medication. And there's not a good integrated discussion about the risks and benefits. So everyone is kind of nervous about aggressive management. So when we're looking at these problems that we have on our med surg unit, we think about the type of patients that would be better served on a med psych unit. And so I am not going to read off all of these, but these are the typical medical diagnoses that we might see on a med psych unit. And these are medical diagnoses that can have significant psychiatric or behavioral health symptoms co-occurring with them. Psychiatric disorders, a lot of patients will have a mood disorder, schizophrenia, or a suicide attempt. Often, most units, do not focus as much on PTSD or personality pathology. There are some that focus on eating disorders, and then there are some that focus, like I said, primarily on delirium, where the underlying mental health issue, might just be an encephalopathy causing symptoms, not a primary psychiatric diagnosis. There are potential benefits to a med psych unit. So for the hospital, often we see the length of stay will improve on med psych units for these patients over if they had been cared for on the med surge floor. We see also that sometimes readmission rates are lower for these patients when they get more integrated care. There is often less restraint use used on the patients on a med psych unit, and there's also staff burnout improves. As I said, these patients, the med surg units are ill-equipped to take care of these patients, and patient safety events also go down. For the patient, they benefit from care integration and concurrent care. And with less restraint use, there's reduced iatrogenic injury, and patients don't like being in restraints. There's also reduced stigma towards their mental health diagnosis on units that are designed to care for them. So in practice, I think, discussing management is helpful. So in practice, if we go back to our first case, our 41-year-old guy with bipolar disorder who's manic, who has an AKI and rhabdo and has agitation that's interfering with care, where our as needed medications aren't working well. So here's how we would see the differences. So on a med surg unit, we would have PRNs ordered, but no standing medications. On a med psych unit, we would have scheduled mood stabilizers, antipsychotics, and aggressive escalating PRN management from the get-go. On med surg, agitation would be treated with restraints and sometimes medication if the nurses felt it was safe to administer the medication. On med psych, we would use restraints as a last resort until chemical sedation occurs. So we are very focused on getting the patients, calm and able to participate in care, or even just in this situation, potentially sleeping to allow care. So on the med surg floor, ineffective agitation disrupts care, whereas on the med psych unit, aggressive agitation management facilitates care. So we often see that a CPK will increase with restraint use and ongoing agitation on the med surg floors, whereas on a med psych unit, the CPK improves with continuous fluids and agitation management. So some of the challenges that we see for med psych units, because these units sound great, but there are challenges that lead to us not having more of these units. It is hard when there is a new service that has not typically been around before and trying to get people to buy into that, especially when it benefits mostly patients that have historically had a lot of stigma attached to them. Their regulations are also an issue. You often have to design these units that meet medical and psychiatric regulation requirements. And so they have a little bit more scrutiny of what they look like. Reimbursement structure is difficult in the US. You can't have like a dually trained medicine and psychiatry person bill for medical and psychiatric services in the same day. So you can only bill for one or the other. And so even if you have a co-managed service, you can't bill for both inpatient medicine and inpatient psychiatry. So there has to be a consultant fee for one of those services. So, they're not especially profitable. And overall, they usually are cost saving versus money making. And so we will see cost saving potentially in length of stay and readmission rates and stuff, but they don't produce a lot of money. Staffing can also be an issue. A lot of times people feel very strongly about either being a psychiatric nurse or a medicine nurse, and there are not as many people who fall in between who want to do both. And so they can be hard to find people who want to work on a med psych unit. So I want to talk a little bit about our med psych unit at Grady. And this is some of our staff on our opening day in October of 2023. And it opened after over 2 years of planning. And the goal for our unit was to provide care for high acuity psychiatric and medical patients. We are financially supported via the state of Georgia. So they were the ones who came in and kind of worked with Grady to pay for the unit. And we are the only med psych unit in the state of Georgia. This is the physical space of our unit. So it is one long hallway. This is standing at one end with a picture down to the other end. And all the rooms come off of this single hallway. There are 16 single rooms, and this is what one of the rooms looks like. You can see it's sparsely decorated. We have hospital beds. They can do the same thing that other hospital beds can do. But you'll notice that where there would usually be like a hole or a gap in the med-surg hospital beds, there's none here, and that's to reduce ligature risks. We have a desk that patients can sit at. Again, that is flush against the wall to reduce risks. And we have very, very heavy chairs that they can also sit in to hopefully reduce them becoming projectiles. We have private bathrooms for each patient. These look very sterile, and part of that is because they also have to be designed for low ligature risk. There's a lot that can happen in a bathroom where people can tie a sheet around something and potentially injure themselves. And so the bathrooms have to be designed specifically for that. And similar with the sinks, we don't see like a faucet that would be typical on other units just because of that ligature risk. We have two group rooms, one on each side of the unit, and here patients can come and watch TV. There's a projector that projects the TV on the wall. They can do groups in here, they can eat their meals, they can hang out. There's a phone in here that they can use. So for our med-psych unit specifically, our inclusion criteria is the patients have to be 18 years or older. They have to have a medical indication for admission, and they have to have a psychiatric or behavioral health symptom that is impacting their care. And our unit is a locked unit, and we take away patients' belongings on the unit so they don't get their phone, they don't get access to anything else. And so for us, they either have to meet inpatient, like psychiatric hold criteria, involuntary commitment criteria, or they have to sign in voluntarily to come to our unit and agree to get everything taken away. Our exclusion criteria is if there's specialized care, either ICU or nursing care that we can't provide. If a patient is in custody, we cannot have them on our unit. We're not contracted with the jails for behavioral health care. And there's a lot of logistical issues with having officers on our unit as well, in terms of them potentially like interfering with other care or having things on them like guns or tasers. And then also if psychiatric symptoms are mostly attributable to a non-modifiable condition. And so for people who have dementia with behavioral disturbances, where it would be very hard for us to modify that, that's an exclusion criteria for our unit. Same with some traumatic brain injuries and some intellectual disability. Now, if someone has a long history of schizophrenia and has had some dementia, set in, but a majority of their symptoms are caused by their psychotic symptoms and their schizophrenia, then we can take that patient. It just can't be something where the only problem is kind of a non-modifiable neurocognitive disorder. So what can we do on our unit? So first, our unit has locked doors with limited access. There's sally port doors, which means that there are two doors and they cannot be open at the same time. And that's really to prevent elopement. So even if someone gets out the first door, then they're stuck by the second door and it gets kind of stuck in between. We have video surveillance in the rooms and in the hallways. And so we're able to monitor the patients at the main nursing station while they're in their rooms. We don't have video surveillance in the bathrooms, but the bathroom doors can be locked so that, we would have to let people in if we had any concerns about their safety. We are able to do telemetry. We have 8 telemetry boxes on the unit, and that has actually been pretty recently that we've gotten those, and it's great. We're able to do IVs and we're able to do oxygen. We can do CPAP and BiPAP if it's at night. If the BiPAP is ordered for respiratory distress of some sort and needs to be continuous, then they would have to move to a step down unit or the ICU for that. So our unit staff, we have 8 attendings. Here are 7 of us. We have 3 overnight APPs that do cross cover on the unit that are primarily medical APPs. We have 18 nurses total between day and night and 18 nurse techs. And we have 4 as needed positions too for nurses who come in and help pick up when we need extra shifts taken care of. There are 2 nurse managers, 3 social workers, and 2 clinicians. And so one of our clinicians is a peer specialist. The other one is an LPC, and they do groups on the unit or they do individual therapy with the patients while they're on the unit. Our staffing ratios, so we have an 8-to-1 attending ratio. So a majority of our attendings are med psych trained, and we have one attending who is a med peds attending but worked on a med psych unit before. But at all times, a med psych attending is responsible for all the patients on the unit. So even when our med peds attending is seeing patients, the med psych attending is overseeing their psychiatric care. And so ours is currently the only unit in the world that where every patient is followed by a dually trained attending. We have a 4-to-1 nurse ratio, as well as a 4-to-1 nurse tech ratio. So we have lots of techs that are capable of sitting with the patients, helping them with stuff, which is really great. We have a roughly 8-to-1 social work ratio. Our social workers work 4 10-hour shifts Monday through Friday. And so most of the time there are 2 of them there, but there are some days where all 3 are there. We highly value multidisciplinary care. So this is a picture of our daily treatment team that includes members of social work, the physicians, our clinicians, as well as nursing management and charge nurse for the day. And oftentimes we'll have other hospital staff come, like the chaplain or potentially even like PT or dietary will stick their head in and talk a little bit about patients. We are a closed aggregated unit, and so all of our patients are on that unit. All of our staff is, pretty much the same. There's not a lot of rotations, and we all know each other very well. And so all staff is co-located. This is our doctor room, but if right next door is the social work room, and then there's the unit right next door. So we're all very close, very easy to talk to each other in person. We have a small core staff, and so we all know each other, and that makes it really easy to work with people. And because of that, we also have a lot of familiarity with our patients. So patients that stay there for a long time, everyone gets to know them, everyone gets to know their family, and there's just a much larger knowledge base about the patients that get retained because our core staff is so small. For reimbursement, because money is important, we are a primary med surge unit, and so we use medical billing codes primarily. Like I said, because we are all med psych trained, we can't bill for medical and psychiatric services in the same day. So we use time and complexity based billing on the medical side for stuff, which is pretty standard. And then we use time add-on codes. So there's 15-minute increments that you can add on for psychiatric. which we use for the psychiatric complexity, like talking with families, getting collateral, managing behavioral issues on the unit. Most of our patients get reimbursed by the state of Georgia if they're uninsured, which a lot of our patients are. And so um, that is helpful that we get payment back for those patients. When we look at who's on our unit, we have most of our patients are in this 27 to 53 range, although we do have some younger patients, 18 to 26, and also some older patients in the 54 to 82 range. Our patient population reflects a lot the patient population at Grady. So probably about 70% is Black or African American, and then a quarter is white or Caucasian. And then our patients, we have slightly more male patients than female patients, but overall fairly even. These are our top 5 medical diagnoses. So encephalopathy, seizures, AKI, anemia, and rhabdomyolysis. And this is our top psychiatric kind of billing code. Psychosis is there because oftentimes when we don't know what is causing someone's psychosis, that we just bill as like a psychosis NOS or unspecified, and then we try to specify as we know more. We have a lot of schizophrenia, a lot of bipolar disorder, and a lot of catatonia. For discharges, we discharge a majority of our patients to home or to self-care, and about a fourth of our patients to inpatient psychiatry. And then we guarantee that they have a mental health follow-up within 2 weeks. We do primary care based on needs. And so some of our patients come in, if it is, rhabdo either from like amphetamine use or potentially from being manic and it resolves and they don't absolutely need to see a primary care within 2 weeks of discharge, we might not set them up for that. But if they have chronic medical problems, then we will arrange for them to get a primary care appointment. And then one of our clinicians does a follow-up call within 2 weeks. So we will look at data. Our average length of stay is right a little bit above 9 days, and that tracks exactly with the psychiatric length of stay. So you'll see that medicine tends to be lower, around an average of 7 days. But interestingly, patients that are seen by the psychiatric CL service who are medically admitted have a longer length of stay at 10 days. I think what's important here is that our length of stay is similar to the inpatient psychiatry length of stay, but we're discharging a majority of our patients home, which means that in the amount of time that it would normally take a psychiatric unit to stabilize the patient, we're providing medical and psychiatric stabilization. And so I think that it is not surprising to me that our length of stay tracks according to theirs. And, I think it's really good that it's about the same and not significantly longer, given that we're dealing with medical and psychiatric illnesses. This is our 30-day readmission rate, and so we're at about 11%. Psychiatry is very low. At Grady, it's about 5%. And then for patients that are seen by the psychiatric CL service, they are around 18%. And then medicine is higher, typically above 20%. And so I think what's also important here is that when we look at our readmission rates, we're counting inpatient psychiatric readmission or inpatient medical admission, where psychiatry is really counting psychiatry only and medicine's only counting medicine. So we're getting a double hit on a readmission potential, but our readmission rates are still much lower than medicine, which I'm also very happy with. I think we're doing a lot in discharge planning that's accounting for this. When we're looking at readmissions, we're looking at who they get readmitted to. A majority of the time, within 30 days, they're getting readmitted to medicine, which suggests that our psychiatric stabilization is still happening, or full psychiatric stabilization is happening within the amount of time they're on the unit. So I want to talk about outcomes a little bit that goes beyond data because most of us went into medicine to help people. So these are some real world examples of people that have come into our unit. So we had a 39-year-old man coming in with first episode psychosis. He had this episodic agitation and destructive behavior, including like ripping down a TV monitor, with periods of like regret and awareness in between. And so his kind of like inconsistent psychosis made us concerned for a medical process. We got an EEG and an MRI, and it turned out he had temporal lobe epilepsy that was causing these episodes, and he was placed on Depakote and did really well. We had another woman who had a history of lupus and bipolar disorder. She came in manic and with a lupus flare. Initially, her workup wasn't really consistent with neuroinflation or lupus cerebritis, but she was treated for, a regular lupus flare and her mania, but she did not improve really at all, and she kind of had this waxing and waning mentation. And so we went back to rheumatology and we did a course of high dose IV steroids for her. And in that time period, her waxing and waning mentation and some of the delirious symptoms like completely resolved and got a lot better. Her mania was still there, and she still required treatment for that. But she had an overlap of neuropsychiatric lupus and bipolar disorder. And then we had a 58-year-old female with no past medical history coming from Ethiopia with manic symptoms. She had an extensive workup, MRI, EEG, LP. There was no cause identified. And a lot of people would say this is too old for a first episode of mania. If it's a primary psychiatric etiology, but it turned out that she did, in fact, just have bipolar disorder and she did well on Abilify. And then the last patient I'll highlight is a 60-year-old man with a history of schizophrenia, came in for altered mental status, functional decline over the last few months. When we saw him, he was bedbound and peg dependent on admission. And we realized he had a lifelong history of being stabilized on clozapine, and he had been taken off of it many months ago. We restarted the clozapine, and at discharge, he was able to eat all of his meals and was walking with a rolling walker, completely talking back to how he was months prior. And he had clozapine-induced delirium and catatonia. And so all of these cases are interesting, and maybe eventually these patients, if they had been on a med-surg unit with a medicine team and a psychiatric consult, would have gotten these diagnoses. However, I think that would be hard to happen outside of a unit like ours, because the med-psych unit really gives us the tools to figure out what's going on with patients by having consistent staff that sees the patients the entire stay. And we also have a fairly small pool of doctors that communicate with each other closely, and consistent social workers and clinicians. So when all of that is paired with doctors who are duly trained in medicine and psychiatry, who know how to interpret the data and put the pieces of the puzzle together, it allows for these complex diagnoses to come to light. And so I really think there is a very unique role of the unit plus the doctors. So the lessons we've learned are that outcomes are hard to measure, but that inequity and stigma is fairly pervasive throughout the healthcare system. We're also practicing between the cracks. There's no one who's giving evidence-based, research on our specific patient population on what to do with people with very high medical and psychiatric acuity. And so oftentimes we're improvising, try to, figure out what is potentially best for the patient, trying things and then reevaluating. But it's difficult to do that. I will say that core staff and aggregation is invaluable, and that shared values really improve resilience. For our future directions, the Association of Medicine and Psychiatry also has this MedPsych Unit Consortium. And so we are working to collaborate with them on data. It's very hard to get data on MedPsych units because once the unit is started, it changes the landscape of the healthcare system. And so it's very hard to compare the patients once there is a MedPsych unit, patients on the unit, to any other patients in the hospital. And really the only way to do that would be looked back at at how, like, what patients were doing before the med psych unit started and looking at psych consult liaison patients. But that's also very time intensive because it's not all the patients. You'd have to go back and pick through patients that you think would meet criteria retrospectively. So it's hard to get good data. There also has been a lack of definition of what a med psych unit is, which has made it hard to compare across different countries or in different units. And then also we are working to compare different med psych units. And I'm working with the med psych unit consortium to talk about our unit and also compare it to a new unit in the Netherlands and South Korea. And it's really interesting to see how these units developed using kind of their healthcare history and current system. We're also looking to kind of try to help with inequity in the future. We're ideal advocates for our patients since we can understand and weigh both the psychiatric and mental health conditions. And so, for example, recently with the Ativan shortage, we noticed our patients with catatonia were having a much longer length of stay and weren't responding as well to other benzodiazepines. And we went to the pharmacy and gave them some examples, and they actually approved IV Ativan for refractory catatonia as well as seizures, which like immediately improved some of our patients and made a really big difference for us. And it reduced our length of stay. And we're working on education, educating people about our unit, about what we do, and about our patients. And then we also are working to start publishing some data from the unit. We do have this case report that was published by some of our med psych residents. But since our patients exist outside of the medical literature, it really influences the care they receive. And we have, I think, a responsibility to publish like what we're seeing to talk about our patients and hopefully outline a roadmap for approach and outcomes for other people to follow. We also have IRB approval to start publishing the data from our unit, like with basic outcomes like the length of stay, readmission rates, that kind of stuff. So that should be up and coming, and hopefully we can contribute to the literature. So in conclusion, mental and physical healthcare have developed mostly independently without significant integration. Silos of these of mental and physical health really hurt patients, practitioners, and hospitals. And med psych units can be really beneficial to promote integration, manage complex diagnoses, and improve hospital and patient outcomes. And I just want to say thank you to all my med psych colleagues, the MPU consortium, GIM family, and of course, my med psych family.
Thank you, Dr. Gensler, for that excellent presentation. I really appreciated your thorough review of sort of how this all started and how it's evolved over time. I think is really informative for many of us. What questions do y'all have? We can enter them in the chat. It may be that you have answered all of our questions already, Dr. Gensler. Here we go. Have you had any patients admitted to medicine who then get transferred to the med psych unit?
Yeah, so this is actually a majority of our patients because we only admit really during the like 7 to 7 when our attendings are there, and oftentimes our unit will fill up, so we have to wait for a bed to open. So a lot of times patients will get admitted to medicine first, and then the psych consult team might see them, or they might just refer directly to us, and we will transfer them to us when we have a bed. But we also get people from the inpatient psychiatric unit as well as the psychiatric ER.
It seems like most of your patients are housed. Is that accurate? Housing was our biggest issue in another unit.
I will say no, a majority of our patients are not housed, but that our social workers are amazing, and that they find places for our patients to go that I never would have guessed existed. And so we use a lot of creative solutions to try to get our patients housing. And our social workers have a lot of relationships with people in the community for like personal care homes, that kind of stuff, who will also work with our patients to get Medicaid potentially and apply for them. So we're just extremely lucky.
It's true. Having amazing social workers makes such tremendous differences in outcomes across patient populations.
Yes.
Uh, Another question, are we able to transfer from a different hospital to your unit?
Yes. So the state of Georgia, we have about 2 to 3 beds that are reserved for non-Grady patients. And so the way that you would refer a patient to our unit is you actually do it the way you would refer a patient to Georgia Regional or other psychiatric hospitals, which is this huge psychiatric hospital bed board. And so you would refer to that. And then once they realize they have a medical condition, it gets shunted to us for review. Now, we often do not have beds to take outside hospital patients, so it's not that common. We have to prioritize like Georgia Regional patients first, or Savannah also has another Georgia Regional. So those are our biggest things, but we do sometimes take patients. I mean, probably like once every 2 months.
You mentioned that MedPsych does things differently at discharge compared to Med-Surg, and why that must be, maybe why the 30-day readmission rate is much lower. What is different at discharge with the MedPsych unit?
Yeah, so I think part of it is our social workers are amazing. Part of it is that like we will cold call people until we find like a family member that they haven't seen in like 30 years or something. And so we try to really re-engage family. And we also, I think, are providing a lot of psychiatric stability so that they are less likely to get readmitted. But we put contingencies in place, like if this happens, here's what you can do to try to prevent like a readmission and stuff. And we really try to work with where our patients are at, what they're willing to take, and find out a plan. And if we feel like they're not safe to discharge, we don't discharge them too. So I think it's really a combination of a lot of those things.
Any other final questions? All right. Well, thank you again, Dr. Gensler. Thanks y'all for being here, and we hope you have a great rest of your afternoon. Okay. Bye, y'all.